Good afternoon, everyone. My name is Sheila Senyo, Strategic Alignment Specialist for the California Comprehensive Cancer Program and the California Cancer Registry. Thank you for joining us at the last session of the CDOC Cancer Surveillance Webinar Series for fiscal year 22-23. This series is a virtual learning opportunity that will educate CDOC stakeholders and the public on cancer-related surveillance data sources. A little bit of housekeeping. Everyone has been muted, but please keep in mind that our chat is open for any questions you may have for our presenter. We'll open a Q&A after our speaker presents. And today, we'll learn from our presenter, who will present CCR several variables available to researchers that are not or have not recently become available in the surveillance, epidemiology, and end results public use data. Our presenter, Brenda Hofer, manages the surveillance and data use unit within the CalCARES program. Brenda has over 18 years of experience working for the California Cancer Registry program, conducting cancer research and surveillance, serving as a technical lead on the production and evaluation of research data sets and databases. Brenda has authored and collaborated in research studies and numerous surveillance reports evaluating the cancer burden in California. Her interests focus on the cancer disparities and issues pertaining to data quality. She is also a member of the North American Association of the Central Cancer Registries, or NACER, Research and Data Use Steering Committee, NACER Rare Cancers Work Group, and leads a NACER work group developing a handbook for Central Registry data analysts. Brenda obtained a Bachelor of Arts degree in Sociology from the University of California, Davis, and a Master's of Arts degree in Sociology from California State University, Sacramento. Today, she is also joined by Donna Hansen, Lead Quality Control Data Analyst at CalCARES program, to help answer and co-facilitate during the Q&A portion of the webinar. Donna received her CDR certification in 2003 and has 23 combined years experience working in the cancer registry field in both hospital and central registry setting. She is now the lead data quality analyst for the California Cancer Registry, responsible for organizing a team of CTRs in all aspects of CCR data quality activities. And now, I'd like to pass it over to Brenda for her presentation.
Thank you, Sheila, and hello, everyone, and thanks for attending today's CDOC webinar. I am Brenda Hofer, and I have my colleague, Donna Hansen, here with me today. I like to refer to Donna as the CTR extraordinaire. She is definitely a subject matter expert on California Cancer Registry data. We're going to provide a broad overview of the type of data that California Cancer Registry collects and what it does not collect. And at the end, I will touch on some of the newer enhancements to SEER's data. So while I give the presentation, I'm actually going to go off screen, and I will come back on for the Q&A. Okay, my slides are not forwarding. Oh, there we go. Okay, so as a little bit of background, in 1985, state law established cancer as a reportable disease and created the California Cancer Registry, or CCR. Statewide reporting began in 1988, and CCR currently has 33 years worth of complete data, which includes cancers diagnosed from January 1st, 1988 through December 31st, 2020. In 1994, CCR became part of the Center for Disease Control and Prevention's National Program of Cancer Registries, and in 2000, all of CCR became part of the National Cancer Institute's Surveillance, Epidemiology, and End Results, or SEER program. The CCR is a program of the California Department of Public Health, Chronic Disease Surveillance and Research Branch. CDPH partners with UC Davis Health to manage the day-to-day operations of the central registry, and also partners with 3 regional registries on data collection. These 3 regional registries are the Greater Bay Area Cancer Registry, housed within the University of California, San Francisco, the Cancer Registry of Greater California, housed within the Public Health Institute, and the Los Angeles Cancer Surveillance Program, housed within the University of Southern California. CCR data meets national standards set by both SEER and NPCR for quality, timeliness, and completeness. CCR has also continuously received the highest certification possible from the North American Association of Central Cancer Registries, or NACER. CCR is a population-based cancer registry and collects information on all reportable cancers diagnosed among California residents. Reportable cancers include incident or new cases that are in situ or malignant behavior, with the exception of non-melanoma skin cancers and carcinoma in situ of the cervix. Benign and borderline brain and central nervous system tumors have also been reportable to the CCR since 2001. Cancer cases are reported to the CCR by hospitals, pathology labs, physician offices, and treatment facilities. CCR is a very large and rich database. It contains approximately 5.8 million cancer cases, and approximately 190,000 new cases are added annually. The number of data items pertaining to each case varies, but is approximately 500 data items per case. So what type of data does CCR collect? CCR collects information on patient demographics, including age at diagnosis, state and country of birth, race, ethnicity, and sex, to name a few. In 2015, the codes for sex were expanded to include transgender persons. CCR also collects data on tumor characteristics and prognostic factors, including primary site, histology, grade, behavior, items needed to derive stage at diagnosis, tumor markers, and cancer-specific prognostic factors. CCR collects some risk factor information, including height, weight, and tobacco use. However, these fields have a large percentage of missing values, and the tobacco use fields, unfortunately, do not capture e-cigarette use. CCR collects information on first course of treatment. First course of treatment includes all treatments administered after the original diagnosis, and first course of treatment ends when either the treatment plan is complete or when there is documentation of disease progression, recurrence, or treatment failure. Other data items collected by the CCR include information on the reporting facility and physicians involved with the patient's care, the patient's health insurance type, and follow-up information on the patient, including their vital status, if applicable, their date of death and cause of death. Please note the items that are listed here are only a partial list of the data items and values in these categories. By linking to other data sources, CCR also obtains information on patients' neighborhood socioeconomic status, their area of residence, and additional risk factors such as comorbidities. So beginning with cancer cases diagnosed in 2018, there was a large increase in the number of site-specific data items collected by CCR. These site-specific data items are prognostic factors for particular cancers or data items needed to stage a cancer. And what I've shown here is just a very small example of the 137 site-specific data items that were added to the database in 2018. In 2018, the radiation treatment fields were also expanded to allow for more granularity in volume, type, and dosage administered for up to 3 separate phases of radiation treatment. Here you will see the 7 data items captured for each phase. Additionally, fields were added to capture the total number of phases of radiation administered during the first course of treatment, whether the patient's radiation treatment course was discontinued early, and the total radiation dose administered to the patient across all phases. So, like the rest of the world, cancer registries had to adapt to the COVID-19 pandemic. In June of 2020, SEER provided guidance to cancer registries on how to abstract information pertaining to COVID and record it in text fields so that natural language processing techniques could be used later to extract this valuable information. For cases diagnosed January 1st, 2020 through December 31st, 2022, CCR collected COVID-19 information in text fields. Also for cases diagnosed January 1st, 2020 through December 31st, 2021, 4 structured data items were implemented into the CCR database to capture COVID-19 information. Both text and structured data items captured whether a patient received a COVID test, if the test was positive, the date of the first positive COVID test, and whether the first course of treatment was interrupted by pandemic-related issues. In 2021, CCR began collecting data on recurrence from CDOC facilities and also began collecting data on neoadjuvant treatment. Also in 2021, new site-specific data items were added for lung, colon, rectum, and pancreatic cancer. Beginning in 2022, additional site-specific data items were collected for chronic lymphocytic leukemia, small lymphocytic lymphoma, and for cervical, vaginal, and vulvar cancers. So what data does the CCR not collect? We do not collect patient medical or family history, all known risk factors. We only, like I mentioned earlier, collect information on tobacco use, height, and weight. We do not collect information on cancer screening or sexual orientation. Also, treatment that occurs in the outpatient setting or at home, such as oral medication, is not consistently reported. So before I discuss SEER's data, I just want to give a disclaimer. I don't consider myself an expert on SEER's data or all the variables available in their different databases. But if you go to SEER's website, they have extensive documentation on all their databases, how to access their data, et cetera. But SEER has many derived variables that we also incorporate into the CCR data that are useful for analysis. These include their site recode variables. So they have site recode variables that allow us to analyze childhood cancers, cancers among adolescents and young adults, and rare cancers, to name a few. If you would like more information on the numerous recode variables SEER offers, please visit the webpage listed here. One of the newer enhancements to SEER's databases is the addition of county-level attributes from the American Community Survey data, including information on socioeconomic status, nativity, language isolation, migration, and many more. These data can be used to calculate incidence and mortality rates by each attribute, for example, by socioeconomic status. To learn more about SEER's county-level attributes, please visit the web page listed here. SEER databases also have census tract level attributes pertaining to socioeconomic status and area of residence. And some of these attributes are listed here on the screen. And again, for more information on SEER census tract level attributes, please visit their webpage, which is listed here. In summary, CCR is a large and rich database consisting of approximately 5.8 million cancer cases with approximately 190,000 new cases added annually. CCR data meet national standards for quality, timeliness, and completeness. CCR has data on patient demographics, tumor characteristics, prognostic factors, some risk factors, first course of treatment, and follow-up information. Linkages to other data sources are used to enhance CCR data and provide information on comorbidities, persistent poverty, and socioeconomic status. CCR does not collect information on patients' medical or family history, extensive risk factors, detailed outpatient or home cancer treatments, cancer screening, or sexual orientation. If you are interested in using CCR data for research or need cancer statistics, please contact us at our research email and we'd be happy to assist you. Thank you very much.
Thank you so much, Brenda, for a high-level presentation of CCR data elements that you collect and not collect. And now we will open it up for the Q&A for any question. So please feel free to go off mute or type in your questions or comments in the chat if you have any questions. Or Brenda, did you want to elaborate more on one of the items that you presented? I know it was...
No, I mean, I would just be curious to know if, if this was kind of the overview people were looking for. I mean, CCR data is detailed. It's very extensive. It's hard to know exactly, what people are interested in looking at when they come to the cancer registry for data. I know sometimes it's research specific or project specific, but yeah, I just tried to hit on the key points, the broad points. But if there's something specific people want to know about, Donna and I will take a crack at answering your questions. And people can email me later as well. I put up the researcher email, but we can share my email, my personal email as well. And people can email me if they have questions that they would feel more comfortable asking via email.
Brenda, we received a question on the chat for data.
Okay.
For data requests, how far can we go back historically?
1988 if you want statewide California data. Okay, and is that broken down regionally? Yes, I mean, we can break it down by county, definitely. Sometimes if counts get small, depending on exactly what statistics you're going after, in certain population subgroups, we might have to suppress some counts, but we can break it down by county. We can group those counties into regions. We have cancer reporting regions in California that are well defined, but those were for cancer reporting purposes, and you might have a region that you consider is more useful for you for whatever your program or project is. You're welcome.
I don't think I see any other questions. Like I said earlier, we tend to go fast with these sessions. It's a learning experience for everyone attending. And Before we close this session, we ask that you complete a 5-minute or shorter survey that we have to help us with our future webinars at CDOC. And I have dropped the link on the chat. Special thanks to our wonderful presenter today. Thank you, Brenda. And you may share topics for our future webinars in this series by, again, completing the evaluation form that I just shared in the chat. And I don't see any other questions, so we'll give everyone back some of their time left at this webinar. We thank you all for taking the time out of your busy schedules and for joining us today. We'll be sharing any slide decks in a follow-up email, CDOC website, and CDOC listserv communications. Please enjoy the rest of your week.
Thank you, Sheila. Thank you, everybody.
Yeah.
Bye.